all present here. In our country, quality improvement process at institutional level is monitored by organizations like NABH, JCI, and ISO. However, this at clinical and personal level is not given due importance. However, due to emergence of health tourism and a greater emphasis on the quality of healthcare services, there is an urgent need for implementation of quality improvement process and auditing. I, Dr. Sapna, am very pleased to invite you all to this first of its kind international symposium on quality improvement process and auditing in health sciences, a webinar organized by Rajiv Gandhi University of Health Sciences and Bangalore Academy of Periodontology as a part of their Silver Jubilee celebration in association with D.A. Pandu Memorial RV Dental College. It's a privilege to have with us two renowned speakers, Dr. Douglas Robertson and Dr. B.S. Keshav Prasad, who are here to enlighten us on this very important topic. Deepa Jyoti Parabrahma, Deepa Jyoti Janardhana. Deepo me haratu papam, Deepa Jyotir Namostute. Light represents Agni. It also symbolizes abundance, prosperity, and knowledge. Lighting the lamp removes darkness, ignorance, and unhappiness, and is regarded as to bow down to knowledge. So, let's do a Sashtanga Namaskaram to the knowledge by lighting the lamp, though virtually this time. So, let's begin our lighting the lamp ceremony.
Gurutvam kalyanam arogyam dhanasampadam Shubham kurutvam kalyanam arogyam dhanasampadam Shatru buddhi vinashaya Deepajyotir namostute Deepajyotir namostute Shubham kurutvam kalyanam arogyam dhanasampadam Shubham kurutvam kalyanam arogyam dhanasampadam
Let's start our session now. But before we begin our session, I would like to welcome our guest speakers for today, Dr. Douglas Robertson and Dr. Keshav Prasad, who have taken time out of their busy schedule and have graced this occasion. Thank you very much, sir, and welcome to the program. I welcome Dr. Asha R. Iyengar, Principal, D.A. Pandu Memorial RV Dental College, who is very supportive in conducting this program. I welcome you, ma'am. Now I welcome our beloved Sir Dr. Muhammad Faizuddin sir and Dr. A.V. Ramesh sir to this program. Welcome you, sir. I welcome Dr. Sucheta, Head of the Department, and I welcome all the participants who are present here to this one of its kind international symposium on quality improvement process and auditing in health sciences. Once again, I welcome you all to this program, and I hope at the end of this session, you will have an enlightened knowledge on this topic. Thank you. Now, I invite our moderator for this session, Dr. Sucheta A., Professor and Head, Department of Periodontics, to introduce our speaker for this session, Dr. Keshav Prasad. Over to you, ma'am.
Thank you, Sapna. It's my pleasure to introduce my colleague and friend, Dr. Keshav Prasad B.S., He is currently professor and head of the Department of Conservative Dentistry and Endodontics at DAPM RV Dental College, Bangalore. He has completed his BDS from MR Ambedkar Dental College and Hospital, Bangalore in 1993, dentistry and endodontics in 1998 from SDM Dental College, Dharwad. He has teaching experience of 23 years and he is a recognized PG and PhD guide from Rajiv Gandhi University of Health Sciences and also a member of PG Board of Studies of RGHS. He is the IQAC NAC coordinator at DAPM RV Dental College, Bangalore, and he has many articles in publications in international and national and state journals. He has contributed chapters in 4 textbooks and he has presented papers and posters in various international, national, and state conferences. He is a reviewer for various national and international journals. Over to you, Dr. Keshav Prasad B.S.
Namaskara ಎಲ್ರಿಗೂ. Good afternoon, good evening for people who have joined us from around the world. Thank you very much, A.V. Ramesh sir, Faizuddin sir, Suchita ma'am, for introducing me to this program. It's my proud privilege to talk something about auditing in academics. Uh, I would like to start with I'll share my presentation. Share ಆಯ್ತಾ? ಬರ್ತಾ ಇದೆಯಾ? Is the presentation visible?
Yes, sir. It is visible, sir.
Okay. Now, what is this academic in health sciences? Let me start off by saying what Aristotle said in somewhere in 384 BC. Quality is not an act; it is a habit. So, if we go listen to what Aristotle has said, the quality has to be maintained, and when he can say that quality is not an act; it is a habit, we need to practice quality in education. Now, what is this process? The process of academic auditing intends to monitor, enhance the quality of education through proper guidelines for both teaching faculty as well as students, so that we can ensure qualified professionals and researchers to come out from an educational institution. Now, for proper functioning of academics in an educational institution and to quantify the efforts dispensed by the faculty and students, some kind of assessment components have to be designed and have also been designed. And these include the assessment of course delivery as well as what is mentioned in the syllabus. Now, the academic audit, like more traditional program reviews, is a peer review process including a self study and a site visit by peers from outside the institutions. Now, the purpose of an academic audit is to encourage departments and the institutions to evaluate their education quality processes, the key faculty activities required to produce, assure, and regularly improve the quality of teaching and learning in an institution. An audit asks how faculty approach educational decision making and how they organize their work, use their resources available to them, and working collegially to provide quality education in the best interests of the discipline and student learning. Now, NAC is something which has given out good guidelines to conduct academic and academic and administrative audit. Now, each institution also follow their own process. Now, NAC is something called as National Assessment and Accreditation Council. They have evolved tools and guidelines to improve the quality of different levels of higher education institutions for its sustenance. Now, each institution is expected to start off with an internal quality assurance cell. Thereby, they can undergo external quality assurance process, which is possibly done to strive for more excellence so that you provide good education for the students. Now, academic and administrative audit are very essential for excellence in higher education. All these are interrelated concepts. Now, in order to have a quality oriented academic, there should be a strong academic, strong administrative background. What is this academic audit? Now, if an institution is going in for NAC accreditation, they expect the institution to conduct academic audit every year. Now, uh, as an institution, RV Dental College, we are going in for the third cycle. Now, every year there is an academic audit that is being conducted. Now, academic audit is an exercise which serves to provide assurance that the delegated responsibilities for quality and standards of academic provision are being appropriately discharged. Now, to put it in more simpler words, academic audit can be understood as a scientific and systematic method of reviewing the quality of academic process in the institution. It is related with the quality assurance and enhancing the quality of academic activities that are conducted in any kind of higher education institution. Now, how important is this academic audit? Now, it is basically done to encourage the departments or institutions that conduct various programs to evaluate their education quality process, the key faculty activities required to produce, assure, and regularly improve the quality of teaching and learning. Now, what are the basics of auditing? Auditing is basically done for accounting system, confidentiality. It is work performed by others for better independence, internal quality assurance in the form of internal control, better documentation, better planning, integrity, objectivity, skills and competence to be improved for students and as well as faculty. Again, documentation in the form of audit evidence. Finally, audit reporting. Now, once we know the basics, what are the objectives of doing an academic audit? It is
Dr.
done,
Keshav,
sir,
Dr. Keshav, sorry to interrupt.
sir,
In the screen in the bottom, you can see there is one hide.
hide.
Can you click on hide?
Uh, Sorry, sir.
Yeah,
Yeah, I have done it. Sir,
please proceed.
am I clear and audible?
Yes. All the slides are clear. Your voice is very clear. Don't worry. Go ahead.
Okay,
Thank
sir.
you.
Excellent. Now, what are these objectives of academic audit? Now, auditing is done to understand whatever existing system is there in an institution, to assess the strength and weaknesses of the departments and administrative units, and also to suggest the methods for improvement and for overcoming the weakness. Now, if you take it as a first objective, each institution has got various departments. Now, each department is expected to undergo a SWOT analysis, that is the strength, weakness, opportunities, and weakness of each department. Now, by doing a SWOT analysis, you are able to know where you are falling short. So that should be the first objective of an academic audit. The second one is to identify the bottlenecks in the existing administrative mechanisms. That is why when I started off saying academic audit and administrative audit go together. Now, if you have to have a good academic performance from both the teachers and students, you need to have good administration and a good administrative mechanism so that there are no issues, no problems happening with academics. Now, it is also done to identify the opportunities for academic reforms, administrative reforms, and examination reforms. The third one is to evaluate the optimum utilization of financial and other resources. Now, all this, the financial and other resources fall under administrative audit, which in turn help in better academics. The further objectives are to suggest methods for continuous improvement of quality, keeping in mind criteria and reports. I'll come into the different criterias which help in academics. So, our academic audit also ensures a very good accountability. Then it also defines the quality of each component of the functionalities and also ensures the quality of education. Finally, it defines the effectiveness of teaching learning process and also helps us to devise different methods to confirm maximum output from the faculty members as well as students. Now, a relationship between teachers and students goes hand in hand. Now, the maximum output has to be from a teacher so that there is very good outcome from a student. Now, academic and administrative audit. Now, both these are done both internally and externally, and both of them go hand in hand. Internally, it should be done by the internal quality cell of any kind of institution, while externally it can be done by the university, by the affiliated university, or if it is a deemed university, they can always expect people from outside to come and do an audit, or by other subject experts, what we call it as peers. Now, what is the methodology formed? First one is the criteria. Now, the IQAC cells of any higher education institution can decide with a set of criteria to be used for both academic and administrative audit. Now, a lot of institutions which undergo NAC accreditation, they follow the guidelines given by NAC. Now, NAC doesn't specify that it has to follow whatever NAC has said. The institution as such can frame their own guidelines, and they can have a periodic assessment and simultaneously have an accreditation by NAC. Now, by having or by following these criteria, the education system can be definitely be improved. Now, once you have a proper criteria, the second thing that you need to follow is periodicity. When should you do it? Now, preferably, any AAA audit has to be done on an annual basis. Now, how do you select the peers or experts? Now, the peer review is backbone of academic and administrative audit. It is very similar to accreditation that has to be done by NAC. It is always better to select good experts, subject experts who can come and assess the institution. Now, the process is, like I said, it can be devised by the institution. It includes self-evaluation by faculty and administrative units, schedule of on-site visit, formatting of the report, and the outcome. Now, what is the outcome? Now, once a peer review is done, once the reporting is done, the outcome of academic and administrative audit may be placed before the internal quality assurance cell and the governing bodies of the higher education institutions. The plan of action can be prepared to implement the suggestions accepted by IQAC and the governing body. Now, internal AAA is done, like I said, by the IQAC of the institution, and it has to be done at a regular interval to review the program, the activities that are done at the department level, and the institution as a whole. Now, what are the members, or how many of them are there in the internal audit team? Usually, the internal audit team will consist of 3 to 5 senior teachers of the institution, along with the vice principal and the IQAC coordinator. If needed or if possible, it's always better that you need to have a representative from the management. Now, once we know how the process is done, what are the elements of the academic audit? Now, there's something known as self-study. Now, as a process, what we have done in our institution is each department is expected to have their own uh, study material, or what we call it as a self-study done by each department, where following focal areas of education process is done. Now, I'll just mention the 5 ones: determining the learning objectives, designing the curriculum and co-curriculum, designing the teaching and learning methods, developing student learning assessment, assuring implementation of quality education. Now, going on into each one of them. Now, uh, the curriculum, co-curriculum is already set by the university and Dental Council of India. Any affiliated institution is expected to follow that. Now, most of the institutions follow what is given by the guidelines of RGHS and DCI. So, there are certain methods, there are certain ways of determining the learning objectives. What we need to do is we need to consciously consider what students who complete our courses or should know and should be able to do. It's like whatever we teach them, we need to assess, find out from them whether whatever they're doing, whether it is helpful for them in their future, whether it is helping them for their employment, for their abilities and good responsibilities as citizens of that country. So one more thing that we need to do is we need to speak to them, document the information gathered from them, from their employers, and also from students, senior institution. Now, all these documentation will know whether whatever an institution does, and whether it is helpful for the future of the other students. Second one is designing the curriculum and co-curriculum. There are a lot of universities, a lot of deemed universities where once the curriculum is set, there are no changes happening for a very long time. So on a periodic basis, when you start assessing, we need to determine whether what is taught, in what order, and in what perspective. And we also need to know whether we work collaboratively on these curriculum designs. We also need to know what are the resources available, what are the resources that are being used, whether resource materials are available, will they be used and provided in a proper vehicle to the students. Do we consciously consider how the course is designed, and whatever course that is designed, does it relate to the courses the students take part, whether that is helpful for them. Along with that, whatever curriculum that is designed, whether it is helpful in their out of classroom activities that could complement them or that can further be integrated into the curriculum. Now, along with the curriculum, you need to design proper teaching and learning methods. So, the more of academic auditing that is done, you get to know what is the teaching and learning methods that are being organized by the teachers to the students, what methods the students are exposed to. Do they stimulate student involvement with the material? Do they provide feedback on the students' work? Do we analyze each and every teacher, whether they are following the teaching and learning process on a regular basis? Do we strive for coherence in the department's curriculum? Any change, any addition to the department's curriculum which can help in teaching learning process? Is there any change in educational process? Do we need to work on the process design? Do we identify and learn from the best practices? Now, each department in each institution will have some kind of a best practice, whether that is being recognized, whether that is being evaluated. Further, each department does the teacher is evaluated for his or her teaching and learning methods. And all these things need to be compared with other departments. And in the long run, also, it is going to affect the quality, and you need to compare it with other institutions. Now, by doing an academic audit, when we assess all this, you can compare yourself with the other institutions. Next is the developing student learning assessment. Now, what are the measures and indicators that we assess student learning? Again, if we see RGHS and DCI, they have a set assessment for students. What extra that we need to do? Have we defined proper indicators or measures of the achievement of the students? Is it based upon our stated learning objectives? Do we assess performance only at the end of the course or program, or is it a continuous process? Or do we start at the beginning and ending performance to ascertain their value? You need to decide who is responsible for assessment. Do we work collaboratively on assessment design, implementation, and analysis? Do we base decision on these facts? That is what we need to do for to find out the student learning assessments. Then assuring implementation of quality education. Are we organized to ensure that our mutual department or institutional objectives and priorities implemented on a regular basis or consistently? How do we assure ourselves that content is delivered as intended, that teaching and learning process are being implemented appropriately and consistently, whether assessments are conducted as planned and outcome or the results are used effectively? Do we work collaboratively to implement improvement initiatives? Now, all these will be part of your academic audit. Now, once we set all this, then we can plan and go in for a peer review. Now, peer reviewers are also known as auditors. They are primarily volunteers from faculty of other institutions or from the university. Uh, it consists of 3 to 5 members, and once they visit your institution, they will focus on quality processes. Audit visits are usually typically 1 day per department or an institution, depending on the program that has to go in for an inspection or for change and wants to go in for an academic audit can undergo it in 1 day, and if the institution needs, it can go in for 2 days or 3 days. The auditors get to meet with the departmental heads or the leadership, the other members of the faculty, and students to assess the different teaching learning methods, the curriculum that is being implemented, the assessments that are done. The auditors questions similar to the self-study questions, and they bring out the topics like what I just mentioned before. Now, once the auditing is done by the auditors will sit and write a report. They will highlight the different examples of exemplary practice, noting down areas for improvement, evaluate the department's approach to educational quality practices. Now, this final report can help a department or an institution to change their way of application of their curriculum, the different teaching methods to improve the best practices of the department. Now, once we know who's going to do it, there are certain things like the principles of an academic audit. Now, this defines the quality in terms of outcome. Now, learning outcomes should pertain to what is or will become important for the department students. Learning, not teaching per se, is what ultimately matters. Now, it needs to focus on the process. Now, each department is expected to analyze how the teachers teach, how the students learn, and how to best approach the learning assessment. The department should also study their disciplines literature, collect data, and what works well and what doesn't. Experimentation with active learning should be encouraged. Now, the faculty also should be encouraged to share and adopt their colleagues' successful teaching innovations. Now, each teacher is different. There are certain teachers who come out with different innovations. Now, as a rule or as a principle, the colleagues' teaching innovations also should be implemented. Now, for an efficient work, the department or the institution, they should work collaboratively. It is as a team. The teamwork and consensus lead to total faculty ownership, responsibility for all aspects of the curriculum, and make everyone accountable for the success of the students. A dialogue and collaboration should be encouraged over territoriality and the lone wolf approach. One man cannot do everything in a department. It is always a team effort. Now, all your decisions should be based on evidence. So it's always better you need to have good documentation. Good documentation by the departments will show us where we are going wrong and how well we can help the student. The data collected should be analyzed and the findings incorporated in the design of curriculum, learning processes, and assessment methods. Now, to collect data, we need to have a feedback system where you need to have feedback from all kind of stakeholders, starting from the management, from the peers, from the parents, from the teachers, from the students, and also from the alumni. Now, all these will help in gathering evidence and will help us in effectively uh, provide good quality education for a student. You need to strive for coherence. Now, the courses should be built upon one another to provide necessary breadth and the depth. Now, whatever assessments that are done should be aligned with proper learning objectives. Now, like I said, each department has got its own best practice. Now, it is expected that the faculty should seek out good practices in comparable departments and institutions and adapt the best to their own circumstances. The faculty should share best practices and help raise the bar for their department. Department should continually and consciously strive to improve the teaching and learning. Now, once we know the objectives, principle, the process, the next thing is what are the advantages of having all the academic and administrative audit. Now, starting from students. Now, an academic audit will help in eliminating unnecessary workload and dwells mainly on those essentially required for the success of a student's career. For a teacher, it helps in clarifying their roles and responsibilities, thereby leading to conflicts. For employers, it ensures availability of well-rounded students who can contribute from day one itself. For administrators, it gives an insight into the overall quality of the institution, including its strength, weakness, opportunities, and threats. For the management who are running an institution, it ensures proper use and effectiveness of the process, systems, infrastructure, practices, HR, and facilities in the practice of the institution and to implement corrective measures. I would like to jump on into the 7 different criteria of assessment as per the national as per NAC. There are 7 criteria which we follow. One is the curricular aspect, the teaching, learning, and evaluation, research, consultancy, and extension, infrastructure and learning resources, student support and progression, governance and leadership, organization, management, and seventh one is your best practice. Now, uh, all these 7 criteria of assessment will definitely help in a proper academic audit, help the IQAC, and to run a better institution. Now, for any kind of institution to run, there has to be a very good coordination, a very good relationship between teachers and students. Now, a teacher cannot survive without a student and vice versa. So there needs to be good coordination. There has to be good collaboration. There should be respect, and a teacher should always be available for a teacher, whether it is in the class or if there is a provision outside the class. Teaching is not only for satisfying the syllabus or for completion of the syllabus. The job of a teacher is more. And learning is not to get only a job. Learning is something which is a continuous process and needs to be done as long as somebody is there. Now, to follow all this, there has to be a proper discipline, a democracy, and a decency. Now, going into academic audit and teaching, what we need to see is, and what we need to assess is whether pedagogy as a teaching methodology, is it used? Is a is the teaching properly or instructional designed? And for an institution, what are the instruments, what are the ICT or audiovisual aids that are provided for a teacher to help the student in learning? What are the kits available? What are the materials available? Clinical infrastructure, the labs, how good it is, how the models are, what are the academic calendars planned by the university, planned by the institution, whether all these are completed on schedule, uh, whether a teacher is teaching or making the students to learn, is there proper guidance, is there proper supervision, progress review. Now, to do all this, you need to have something known as a mentorship. You need to have a continuous performance assessment of students done, which in turn will help a teacher in teaching properly. Now, if there is teaching, there has to be learning. What are the different methods of learning? What is the method of counseling that is done? What are the learning resources provided by the institution? Now, based on these learning resources, what is the progression in learning curves? Now, I said something about mentorship and continuous performance. By having mentorship and continuous performance, any kind of institution will have or will be able to recognize a fast or a slow learner, whether they need counseling, whether they are able to adjust, whether they are able to learn the the curriculum part, the syllabus part. Now, if there is a group discussion, how the dynamics between the students are, whether the students are participating in learning, what are the different kinds of field visits, what are the camps that they visit. Now, then further, how do you test the knowledge levels? How do you test the writing skills, oratory skills of a student? Now, the third part of it is after teaching learning, the third one is evaluation. Now, for an institution, what is the good system of evaluation? How is it done? Who is going to do the evaluation? And how effective it is? What is the amount of transparency? What is the confidentiality that is maintained? Is a teacher providing or the institution providing ample amount of question banks? Do they conduct surprise tests? Do they have seminar evaluation where the students are subjected to different kinds of quiz, the drawing test, objective test? Do they build confidence in students for their examinations? Do the departments have any kind of innovative practices? What are the different reforms that are done? And what are the types of malpractices that happen? And how is it maintained? How is it tackled? Now, after curriculum, teaching, learning, evaluation, the third part is the research. Now, research has become a main component for any kind of institution. Now, for an institution uh, to grow in, you need to have a proper provision, promotion, and people to do a research. Now, what kind of facilities, what kind of motivation for the teachers, what are the kind of resources provided by the institution for the faculty? What is the incentive? What is the expenditure? What kind of encouragement is provided? Now, once all this is done, what is the output quantity? What is the kind of quality of research that is done? Now, how helpful it is for the institution or for the society? Now, does student participation in research, is it being done by the students or the faculty helping the students to achieve research? Now, for all this, you need to have good think tanks. So you need to work together as a team. There should not be any ego. Stand alone or with others. Fourth one is consultancy. Now, for an institution to grow, for the image, for the brand of an institution to grow, there has to be consultancy. Now, consultancy comes with the good knowledge of the faculty, and whether this consultation, the consultancy, is it helpful for others? Whether you are going to get good ideas, tools, techniques. Now, what are the outcomes of these research findings that a faculty does? What is the competency, what is the experience or expertise of a faculty of an institution, a higher education institution, to advise people? Now, whatever research, whatever consultancy is done, is it visible, is it published, whether it is whether any outside faculty are there participating in it? Now, finally, how the consultancy helps the society in the whole? Now, along with consultancy, you need to have extension. Now, the collective activity with teachers and students, will it help in extension? Now, after a student passes out, visit is your extensive teaching or your extension, is it helping? Now, the following the research or consultancy, what are the awards and recognition the faculty and students get? Finally, what is the impact on community? Now, is there is the institution, does it have any partnership with local units, industries, and with other institutions, whether there are any joint ventures with non-government organizations or government? After extension, there is something known as services. Now, we expect the higher education institution to provide good coaching and guidance services, counseling services, information placement, extension, health services, and employment services to the students. Uh, Once the student passes out, also, how does the institution help them to further go up in their career? Now, to achieve all this, whether it is curriculum, teaching, learning methods, research, extension, consultancy, you need very good infrastructure. Now, the higher education institutions are expected to provide good classrooms with furniture, space, staff room facilities, office space, principal's room, equipment, charts, models, kits. Now, all these will be part of academic audit, whether whether a higher education institution does it have adequate equipment, whether computers are there, whether proper internet, telephone facility is there, uh, whether proper bus facilities, hostels, TV, newspapers, different kinds of books, and a good interactive website and its contents, a proper vehicle parking, canteen, landscape, all these are part of academic audit. Now, once a good infrastructure is provided, whether a higher education institution does it have ma- a maintenance team, whether the audit will show whether a proper maintenance is done, whether the maintenance team is managing, and who is managing and how they are managing. Again, part of infrastructure is library. Now, for any institution to have very good facilities, the number of books, the function, for how long the library is, what is the kind of distribution system, what is the kind of services they provide, how well the faculty there are aware of the books that they're providing, and what are the different kinds of special connections or the collections that are there. That is part of the library. Now, for the library, who is selecting the books? Are they verified? Whether these books help in importance? How many hours a faculty spends time with students in the library? Whether it has been made part of the timetable of a student's career. Now, once infrastructure library is provided, along with infrastructure, what is the kind of physical education? What are the facilities that are made compulsory for a higher educational institution? Whether they provide sports facilities, whether the students are using it, how many teachers are involved in this, and whether on a regular basis, whether sports is conducted in an institution, whether prizes are distributed. Now, all these need to be documented and shown when an academic audit is done. Now, along with all this, what is the student's progression that happens? Whether good curriculum, teaching, learning methods help in very good results, ranks, what is the kind of dropout rates, how many of the students go in for higher education, what is the alumni statistics of an institution. Now, I said something like going for higher education. What is the postgraduate admission statistics? What is the PG examination statistics? How many of the alumni go on into doing PGs? How many of them go on into doing or land up practicing or land up doing post graduation? All these statistics need to be part of documentation of an institution. Now, once academic audit is done, now, like I was mentioning, academic and administrative audit go hand in hand. It's like hand in glove. So for a good academics for students, you need to have good organization and management. You should have good human resource management. So the non-teaching staff also play a very good role in this. And to run a higher education institution, financial management is a must. Now, all this will form part of governance and leadership. Now, for an effective governance and leadership, you need to decentralize the power. You need to have good group dynamics. You need to have different committees. Now, as part of governance and leadership, we have about 17 committees headed by a principal, and all these 17 committees have got heads who in turn meet on a regular basis. We have put up a timetable where each committee will have at least about 5 to 6 meetings in a year. Now, a NAC, it makes it mandatory that you need to have a grievance cell and also a grievance redressal mechanism, which is again part of the institution. The institution should also should be capable of fighting the court cases. Next is the human resource management. Now, to retain a faculty, the human resource management team has to be good. The teaching, non-teaching faculty should be retained. Any vacancies that arise has to be filled on a regular basis. The institution is expected to comply with all the government norms and policies which keep coming up. Then each faculty needs to be appraisal of each faculty has to be done on a regular basis. Now, for a teacher, every year there is a performance appraisal that happens. Now, what is the kind of improvement? What are the efforts shown by the teacher is also uh, there in the self appraisal. Now, along with teaching learning, what is the professional development that the faculty does, which in turn helps the institution to grow? Now, when we talk about financial management, we need to have proper budgeting. What is the kind of budgeting that is provided to run an institution? Uh, then you need to have internal and external auditing. Now, you need to look out for the mobilization of resources, from where all you're going to get resources to run an institution. How is it going to help a teacher? How is it going to help the student? Now, again, on a regular basis, you need to have stock verification. And as part of mobilization of resource, you need to look out for new sources of receipts. Now, once we mobilize all this, you need to have optimum utilization of all these resources. The seventh one is best practices. You need to assess what are the innovative practices of an institution. Now, all this is done with the help of the internal quality assurance cell of an institution. Now, before I end, I would like to summarize what all things that you need to do in an academic audit. You need to have a good course plan. You need to have a calendar of events planned by the university, by the institution. What is the plan, teaching plan? What are the innovations that are done for teaching, learning, and evaluation? What is the kind of log books? What is the kind of records? What is the performance, the monthly performance reports? All these need to be assessed. You need to see what are the strategies that are put into practice for implementation of outcome based learning. Now, I was talking about the fast learners, slow learners. Now, what is the provision done by an institution for remedial coaching? What is the type of mentoring that is happening? What is the type of counseling that is done by an institution? What are the different programs and activities done by the institution? Next one is research. Whether any kind of research that is being done in an institution, whether the faculty or the students are involved in different kinds of publication, consultancy, projects, whether they have tie-ups with other non-government organizations, with other institutions, with the government agencies, what is the different kinds of collaborations that are there, what is the joint programs that are happening, what is the number of seminars, what is the number of conferences, workshops that are conducted by each department, which in turn is going to help the institution to grow. And what is the number of seminars, conferences, workshops that are attended by each faculty and the student of the college. Then the appraisal, the kind of feedback that is obtained, and the analysis of these feedback of the teachers. Now, once feedback is obtained, what is the action taken report, whether it is put across in the governing body, and what is the growth plan and the personal growth plan of a teacher. There's something known as student satisfaction survey that needs to be done, and the needs and analysis of students that has to be done on a regular basis annually. What are the placement activities or initiatives that are provided by the institutions? How are the institutions helping the soft skills, life skills, career skills, time management? How are they building the image? How are they personally groomed? What are the best practices? What are the green initiatives? How are they managing their waste, uh, especially their e-waste, their biomedical waste? What are the gender sensitivity programs that they are doing? Now, Government of India has come out with an initiative saying that you need to have Swachh Bharat and something known as Ek Bharat Shrestha Bharat, and there's something known as interdepartmental competitions. And what is the interdepartmental interrelationships? What are the facilities that are being provided for the differently abled? Now, all these are part of academic audit, which will be assessed. Now, along with that, how do we celebrate? What are the cultural activities? What are the sports activities? What are the minutes of meetings of the departments, the staff, and the student welfare activities, the different extension and consultancy services, the different community initiatives taken by the departments and the institutions, what are the campus industry interactions, how well the alumni association functioning, how are they helpful in the for the further growth of the institution, what is the kind of interaction, then what kind of resource mobilization can be obtained from the alumni. Then finally we need to have the SWOT, or what we call it as strength, weakness, opportunities and challenges of each department, describing the different initiatives. Finally, the future plans of the department and the institution, so that you can have good implementation strategies and prioritize your plans for further growth and improvement. Now, I would like to conclude saying that the IQAC cell is the most important part of an institution. The IQAC chairman, the principal of an institution is the IQAC chairman, along with the IQAC coordinators and other members help in this academic and administrative audits. And if it is done regularly, it is possible for all institutions of higher education to continuously strive for excellence. The assessment, monitoring, and evaluation of the institutional processes require a carefully structured system, course of action, and procedure of internal and external audits and reviews. If implemented properly and systematically, it will help all institutions of higher education to impart quality culture and perform better in all aspects of academic functioning and performance for the benefit of all its stakeholders. Thank you for your patient hearing.
Thank you, sir, for that very informative lecture. Now, may I request our moderator, Dr. Sucheta A, to kindly take down the questions from audience, if there are any, and pose it to the speaker. Ma'am, you're not audible.
Not audible.
Ma'am?
ಕೇಳಿಸ್ತಿದೆ?
Sucheta ma'am, you're not audible.
I would like to thank Dr. Cat. Years spent post MDS.
Can you hear me? Hello? Hello?
Dr. Suchit,
I would like to thank Dr. Keshav Prasad for having enlightened us on this new and interesting topic. There is one question, Dr. Keshav Prasad. Any training for auditors, or it is simply the years spent post MDS?
Uh, as such, there is no training that is being done. Usually, the auditors are subject experts from other institutions who visit the institution.
Sir, may I ask you a question? How frequently this auditing should be done, sir? Internal audit and external audit?
Ma'am, internal audit should be done annually, and if you have, if you are showing any kind of progress, even quarterly, it can be done, because it will consist of the principal, the IQAC coordinators, and 2 to 3 people from the institution itself, at least about 3 heads of the department, and one representative from the management. So it can be done on a regular basis in a year or annually also. Now, if it is done by the university, it is done annually.
Thank you, sir.
Dr. Keshav Prasad, can I ask a question?
Sir, go ahead, sir.
Dr. Keshav, I wanted to know from you. You have been working in RV Dental College since a long time, and you are
Yes, sir.
there during the entire NAC process which your institution has taken up. I
Yes,
think
sir.
it is going for the third time, or you completed the third
Sir,
NAC.
we have undergone the third cycle now. We have submitted our
Uh,
reaccreditation report in January. So we are waiting for a peer team visit.
Right. Can you just give to the audience what is the perceptible change you have noticed due to this process of auditing and NAC accreditation? How the institution got benefited and how the students got benefited out of this process?
Okay, sir. Sir, if I can tell you, I was mentioning about the 7 criterias of NAC. So I'll
Correct.
go as per those criterias. Sir, I think we are one of the most privileged institutions, but every year, at least 1 or 2 of our faculty have been a part of the university, either as dean, or either as a PhD committee member, or in the BOS of UG or PG. So we have been part of developing the curriculum for last 3 cycles, and again, going on to teaching learning methods, compared to the first cycle, we have been able, in the third cycle, we have been able to implement all the different kinds of teaching, learning, and evaluation methods in our institution. Good IT facilities are being provided for the teaching and the students. We have been able to get very good smart boards, good interaction that is happening. Evaluation process, like we have a mentoring system, and we do something known as continuous performance, wherein every student is allotted to a mentor, and each mentor will have 4 to 5 students under them, and any kind of issues, any problem, they get to meet the mentors, and the mentors also have the provision of calling the students, finding out whatever issues they undergo. Then continuous performance assessment, we have books there wherein we conduct 3 internal assessments. So all these 3 internal assessments are marked in those continuous performance assessment reports. Now, this has helped us in tracking all those slow learners and fast learners. So it is like one-to-one teaching we are able to do. Then research, sir, if I can tell you, we were around 150 publications in the first cycle. Now, as individual teachers, now in the third cycle, we have crossed about 1,200 publications, and there is effective collaborations that are happening. And last year, we got a chance to renew our collaboration with a university in Japan. We then infrastructure, as you know, sir. The, I should be thankful to the management that all kind of facilities they have been able to provide. They are continuously improving. Student support, we have regular sports, we have regular cultural programs happening. Now all these students in turn, now as a policy in third year, all these students are allowed to take up research projects. The Department of Public Health Dentistry divide all these the third years into different batches. They are given different research topics, and we have a separate fund for research as an incentive. Now, this faculty are also uh, pushed on to do further research. Like I said, we have a collaboration. One second, sir. University yesterday. Hello. Sir, we've had a tie-up with Showa University, wherein a faculty can go and pursue his PhD there. So that incentive is given. Now, going on to leadership, from B grade, we have come to A grade in the second cycle, and we are crossing our fingers to go on further in the third cycle. And as a best practice, I can tell you that the maximum number of camps that we were able to do the last 25 years. And one of our faculty was felicitated by Limca Book of Records. He's participated in about 1,000 camps. So that is the kind of progress that has been happening in the last 3 cycles that I've got to see, sir.
Thank you, Dr. Keshav. Thanks for your lucid explanation and a very good presentation.
Thank you, sir.
Any more questions? No? May I request our moderator to kindly hand over the certificate to our speaker virtually? Please, certificate for the speaker. Kindly
Thank you,
accept
ma'am.
the certificate, sir.
Yeah.
Thank
Thank
you
you
for
very
your
much.
next.
Yeah.
Now I request our moderator to kindly accept the certificate. Certificate for the moderator.
Thank you.
They are giving the certificate.
Thank you, Sapni.
Thank you, ma'am. Now, let me call upon our beloved principal, Dr. Asha R. Iyengar, our moderator for this session, to kindly introduce our speaker, Dr. Douglas Robertson.
How bad was the lecture?
Over to you, ma'am.
Good evening and good morning to our friends who joined us.
ಬರ್ತಾ ಇದೆ ನಾನು
So, good evening
45
and good
minutes
morning to our guest speaker for today who joined us. So, it's really a proud privilege for me to introduce the second guest speaker for today, Dr. Douglas Robertson. He has held the position, he's holding the position of Senior Clinical Lecturer and Honorary Consultant in Restorative Dentistry. He is the teaching lead for fixed prosthodontics in Glasgow Dental School, the chair of the Glasgow Dental Staff Association, deputy program lead in MSc Endodontics, the course lead in quality improvement in healthcare, the dental representative of the Scottish Antimicrobial Prescribing Group. To talk a little about his other details, he was born and bred in the west of Scotland. He graduated in 2002 with an honours degree in dentistry and worked in general practice for a year before commencing the hospital jobs in oral surgery, orthodontics, restorative dentistry. Thereafter, he completed his MFDS at the Royal College of Surgeons, Edinburgh, and became a specialist registrar in restorative dentistry. He completed his PhD in the oral complications of type 1 diabetes and completed his specialist training in restorative dentistry, including prosthodontics, endodontics, and periodontics. He has been principal investigator on a randomized controlled clinical trial on denture stomatitis and has worked on oral microbiome. He is involved in the specialist training at and national trials in endodontics in the UK. He also has an interest in dynamic navigational implant surgery. He has been involved in a number of quality improvement projects and teaches quality improvement to master students. We are indeed very privileged to have him here as one of the resource persons. So over to you, Dr. Douglas Robertson, for the next speech.
Thank you. I'm just bringing up my slides. Okay, so or if someone could just confirm that you can see what we've got here. Just my slides are up. Is that okay?
Yes, sir.
That's great. So, okay, well, thanks. Brilliant. Thank you very much. Well, it's great.
Yeah, it's okay. It's not on full screen.
Okay, let's try again.
Yes, sir.
Yeah.
That's it working now, is it?
Yeah, that's right. It's fine.
That's great. Well, thank you very much for the kind invitation. It's really great to be here with you, or not here with you, but to be able to join you virtually. I do hope that we will all just get some benefit as we look at this topic that I want to talk to you about, or I've been asked to talk to you about. And the title I've been asked to speak about is Quality Improvement Process and Auditing in Health Sciences. As has already been mentioned, I've been involved in carrying out a number of quality improvement projects over the years, and we do teach this subject both to our undergraduates and as a particular module as part of the master's programmes. When we think about quality, though, the question might be, well, what is quality? You might think that, for example, on the bottom, I think the bottom right-hand side of your screen, you've got a stamp of approval. I think that's something that you've been learning about already this afternoon. Someone has assessed it and has put that stamp of approval saying that it's best quality. Perhaps quality is something which is a long way off. Perhaps the screen on the bottom right-hand side, bottom left-hand side of your screen, quality is not so much a destination, but quality is an ambition. It's something that we need to aim for, something that might still be a distance away. Or perhaps for you, quality is a destination, the green slide there, the green picture there. It's a place to arrive at. The last thing to think about is perhaps on the top right-hand side of your screen. Well, who decides what's quality? Is it the dentist or the doctor or the pharmacist? Or is it the person who's at the centre of it, the patient? And sometimes whether they are unhappy, whether they are equivocal, or whether they are happy with the quality is actually maybe the most important thing. So we need to ask ourselves the question, first of all, what is quality? How can we improve something if we can't define it? So I suppose ultimately, when we're thinking about healthcare, the most important person at the centre of that is the patient. So in a series of studies, we find out what patients think about what is quality healthcare. And it's not exactly the same as you and I might as dentists or as healthcare professionals think. Very high up the list of what patients are looking for in healthcare is care which is caring and compassionate. People want to be treated with compassion. People want to be treated with care. And so even if they receive technically excellent care in a non-caring way or with a lack of compassion, patients will not see that as quality healthcare. Quality healthcare needs to be in collaboration effectively with all of the clinicians responsible for the patient's care. The patient themselves, they don't want to be excluded from the decision-making process. They don't want to be left out and simply to be operated on without their consent. And effective collaboration, perhaps even with the wider social care team. So quality improvement should be looking at ways to ensure that we're providing caring, compassionate, and collaborative healthcare. It's very important to patients that they have trust and confidence in the person and the people and the systems providing their healthcare. They have to believe that you've got their best interest at heart and that they can trust you to do the job well. And no one wants to have their dentistry or their medicine done in a dirty environment. These are the sorts of things that come up high in the patient's requirements. People want continuity of care. One of the things that is a challenge for me is we get patients referred in from general dental practice. They're seen for a period of time in the dental hospital, and then they're referred back. And one of the biggest challenges is making sure that there is continuity of care, making sure that people don't get lost in the system, and making sure that people, that the general dental practitioner is fully informed of the care so that eventually they can go back to the dentist and receive their primary dental care in practice. So caring, collaborative, compassionate, confidence, clean, and continuity. And possibly it's because it's just expected, we're looking for clinical excellence. So that's really a given. That's what patients think, at least, is that everyone who's appropriately trained will be doing excellent care. I suppose if you were to write that list of quality indicators in your practice, you, like me, would probably have clinical excellence, doing a really good job, an excellent restorative margin, a lovely shade match, successful periodontal surgery, probably high at the top of your list. Patients feel that that's just expected, and so they have other priorities when think about clinical improvement. This is one of these kind of little word maps, a little wordle. And when you speak to patients about quality, the bigger words are the words which come up more often: honesty, caring, commitment, integrated, person-centred, respectful. And the sort of words around clinical and technical excellence are not seen to the same extent. The big issues with healthcare are sometimes the things which perhaps we as dentists might overlook. So there is a healthcare quality strategy here in Scotland, and the three of the big themes in that are that quality care should be person-centred. It's got to be centred on the individual who's receiving the care. Not centred on the dentist or the doctor, but centred on the person. The second big issue is to think about effectiveness, to make sure that patients are getting the most appropriate treatment, the correct interventions, the right support at the right time, and that everyone who will benefit will receive it, and wasteful or even harmful variation is eradicated. What we don't want is one hospital in Edinburgh doing one thing, another hospital in Glasgow doing something else. If one of them's better than the other, then they should adopt the best practice and make sure that it is effective care. And then we need to ensure that the care is safe. We want to make sure that we avoid injury and harm to patients. And some of the ways in which we would attempt to produce a healthcare system that produces quality outcomes would be through a number of terms that I'll introduce to you, or I'll remind you of over the next few slides. I want to introduce you to the term, or to remind you perhaps of the term, clinical governance. This was defined by Scally and Donaldson as a framework through which organisations, NHS organisations, are accountable. So a means by which someone is responsible and accountable for continually improving the quality of their service, safeguarding high standards of care by creating not just dentists who are really good with their hands or surgeons who are really good with a scalpel, but creating an environment in which excellence in clinical care will flourish. And that's the whole framework of clinical governance. And clinical governance can be broken down into a number of different tools in the toolkit that produce clinical governance. We need to make sure that there is education and training, for example. Our staff need to be trained and they need to be able to maintain that training and education. We need to think sensibly about risks and mitigate those risks, reducing the chances of harm and making sure that our patients are safe. It's got to be a culture of openness, willingness to admit when things nearly went wrong and when things went wrong, and to learn from that. We need to think about research and development. We never have, or we don't have the perfect solution for very many healthcare situations. And so we should always be researching and developing new ideas. That has to be part of the process. We need to make sure that we're using these two tools on the right-hand side of your screen: clinical audit, more commonly referred to as quality improvement now, and clinical effectiveness. So clinical governance, using these tools that I've just shown you in the last diagram, clinical governance wants to produce recognisably high standards of care. Transparent responsibility. Who carries the can? Where does the buck stop? Not in terms of blame or attribution, but accountability and responsibility. Because if you're responsible for something, then you want to make sure that it's done well. But if the system's responsible, then perhaps the problem can happen where people are not actually aware. Everyone blames the system and no one takes responsibility for improvement. Accountability, I think I've already covered. And we want to operate within learning organisations. Organisations that are in a constant dynamic of improvement and constantly moving forward. One of the ways that the other term that we use is clinical effectiveness. And clinical effectiveness really probably can be summarized by thinking it's the right patient getting the right treatment at the right time for the right cost. The right patient getting the right treatment at the right time with the right cost. And it's really the extent to which clinical interventions, when deployed in the field, do what they are intended to do. And really that's ultimately what we're trying to promote. And the key elements of clinical effectiveness are similar to that in the previous diagram, but not exactly the same. Research and development is important. If we're going to make sure that patients get the right care, then we need to be doing research to make sure that they get it. We need to make sure that there are guidelines, perhaps locally produced, nationally or internationally produced guidelines, and when they are produced, that we make sure that we implement them in our practice, that we measure our outcomes. It's extremely important that we know what we're doing and we know how well it works. Otherwise, how can we ever improve? Clinical audit, I'll come back to. Education is key. You need to start with an educated workforce, and then we need to make sure that that continuing professional development maintains them at the peak of their abilities. And somewhere in the mix, unfortunately, someone has to pay for all of this. And it's important in a world in which there are finite resources that what is done is not only effective, but is cost effective. And of course, the price for a quality added life year has to be taken into account in a system where there is a finite amount of money. So quality improvement, what's that then? We've established a little bit, I think, about what we're aiming for in quality. We've looked at a couple of the key terms that are used in the United Kingdom to describe how we achieve that, the system of that. Quality improvement is really the means of everyone working together with unceasing efforts to make changes that will lead to better outcomes, better system performance, and better professional development. It's the idea of us always reaching and stretching forward. Sometimes we describe the beginning of a quality improvement project about setting a stretch goal. Don't just aim for something that you think you can already do. Stretch yourself. And so quality improvement is the combined and unceasing efforts of everyone involved, whether that's the professionals, the patients, the family, researchers, the people paying for it, the planners, the administrators, and the educators to make sure that patients get the best outcome. And quality improvement, a lot of the work on quality improvement comes from the Institute for Health Improvement and Donald Berwick in the States. And the aim of the IHI is really threefold. It's first of all to improve the health of the population. Secondly, to improve the experience of care in broad terms. And thirdly, to ensure that the system, whoever's paying for it, gets best value for money. And that's really the triple aim of the Institute for Health Improvement. And quality never happens by chance. You'll never meander your way towards an excellent system. It's always intentional. It always takes effort. It always takes thought, and it always takes skill in the execution. If you work in a system where there is good quality, that quality represents the wise choice of the many alternatives. And that is a quote from nearly 80 years, in fact, 80 years ago this year. Quality needs to be intentional. And so the model for improvement that Berwick suggests is shown in the diagram that's on your screen now. We need to think carefully about what we're doing and why we're doing it. What is it that we're trying to accomplish in this process of quality improvement? And having thought about what we're trying to accomplish, how will we know that when we change something, that change has improved things? And what changes can we make that will result in an improvement? And this is where we're introduced to the PDSA cycle, or the planning an improvement project, doing that project, studying the results of it, acting on those results, and then checking to see whether that made any difference. Planning again, doing a second cycle, studying the results, acting again. And it's not a single cycle, it's a repetitive action. Donald Berwick says of that model that we've just seen, this model is not magic, but he believes that it is the most useful framework that he had encountered in his own work in quality improvement. Plan, do, study, and act. So quality improvement then is the use of those is partly the use of those PDSA cycles. The audit cycle is a systematic process of, first of all, working out what's best practice, measuring your care against that criteria, taking action to improve care, and then to monitor and sustain that improvement. So moving on from the introduction of the PDSA cycle, I want to start to think about how we would plan a QI project. Well, first of all, we need to clearly define our objectives. What is it that you're going to measure? Define your questions. What questions do you want to have answered? How are you going to process the data? Are you going to just do it on a pen and paper? Are you going to do it on a spreadsheet? Are you going to capture it on iPads, or are you going to capture it in paper forms? How will you, what's not so much just how will you get the data, but where along the process? So will you pick up the data as the doctor or dentist is doing the treatment, they will be capturing the data? Will it be a separate system where there's an extra form to fill in? Will it be done by the dentist, or will it be done by the nurse or by whoever? You need to think about the ethics of what you're doing. You need to be careful with data protection, confidentiality, and consent. And then you need a realistic timescale for completion. You need to think, how quickly can we do this? How quickly can we make a change and see an improvement? And then the other thing is, okay, so what? So you've discovered a problem, you've went through a cycle, what are you going to do about it? And here's your basic QI cycle. So you can see you first of all set your standard. Now, if you are a periodontist, you may want to look to the European Society of EFP, European Federation of Periodontology. You may want to look at various local, national Indian groups or international groups and see what standards they have set. And having established a standard, then you may think to yourself, well, does my practice, does my hospital or university measure up to that practice? So we'll test it. Everyone should have a basic periodontal examination carried out on their first visit? Well, go to your notes and see how many of them, how many of them have got a BPE score or a CPI 10. Compare that against the standard and then think, well, we didn't meet the standard, so how can we improve that? Is it a matter of a lack of time? Is it a lack of knowledge? Is it considered not important? Why is there what are the barriers to people carrying out a periodontal examination at every new patient appointment? And then implement your change and then test it again a few weeks or months later to see whether things have improved. One of the things that one of the mistakes that is often made in quality improvement and quality audit work is that you have a small group of people with a big interest in the problem, probably sitting around a committee table and all thinking of how they're going to test what's happening in the clinic. And they sit round the table and they design their forms and they work out what they want and they design. And then once everybody round the boardroom table is happy, it's approved. And then it goes into the real world. And there we discover that the nurse doesn't have time to fill in the form. The dentist doesn't use that kind of charting. The form requires to be filled in after the patient's left and there's no time in the timetable. And we discover that the whole thing fails because there was a lack of consultation with the real world. And so we want to avoid that in our design. So for example, a better approach is to, yes, the boss of the department, the lead clinician, the clinical director, perhaps does need to say, here's a plan. This is a problem. But rather than going through lots of discussion in the boardroom, you take it straight to the clinic. Test it. It doesn't work. Modify it. Test it. It doesn't work. Modify it. Test it. No one's filling in the form. Make the form yellow. Make the form stuck on the front of the notes. Make small changes, iterative changes until you finally get a process that works in the real world. And having got a process that works in the real world, then by all means, get your board to approve it, and then you can implement the process. But it's really important you have these short PDSA cycles rather than a big, long process in the boardroom only for it to fall on its face when it gets to the clinic. This is just a diagrammatic representation of this from the Institute of Health Improvement. Just speaking about, well, first of all, choose your topic, recruit your faculty. Who's an expert in this? Who's involved in the process? And don't just involve the implant dentist and the implant audit. Don't just involve the periodontist and the perio outcomes audit. The nurse is important. The receptionist might be important. The patients might also have a view. So recruit your faculty. Then you enroll your participants. You start the process. And you have a first iteration of your attempt to fix things. Plan, do, study, act. And then review. And then follow that on again. Plan, do, study, act until you finally get, hopefully, each of these cycles results in an improvement. One of the things that people often ask themselves is, well, is this a research project? So before we go any further, I want to just give you a couple of principles that would be a distinction between quality improvement work and research. Research, the aim of research is to derive new knowledge, okay? So you are inventing something, you're testing something that is not yet known. Whereas audit and service evaluation projects, they are to measure what are already established standards of care. So to put it another way, research is to find out what you should be doing. QI work is to find out if you're doing what you should already be doing and whether that is working in practice. If So no audit or service evaluation or QI project is an experiment. What you're doing already has a firm basis in the clinical and health community. People are not receiving treatment by protocol, and people are certainly not randomized into a project. If someone's randomized, if there's a protocol, and if people are being allocated to different protocols, or if it's brand new information, that's research, and that is going to require ethical approval and going to go through a different route. So I want for just 5-10 minutes or so to give you an example of a quality improvement project that was done in the United Kingdom, and Glasgow Dental Hospital played a part in that. So we first of all started off with our objectives, and our objectives were to test whether we were prescribing antibiotics appropriately. So we examined the prescribing practices of both therapeutic and prophylactic antibiotics in the dental school. And we looked at all of the departments apart from our emergency treatment centre. And we decided that 1 month would be enough time in order to capture sufficient data to make decisions. And that was not limited to Glasgow, but it was across the whole of the United Kingdom. So the first question was to establish, well, what is the gold standard that we're measuring it against? And so there are a number of guidelines. So we have the NICE guidelines, so National Institute for Health and Clinical Excellence. There are also guidelines produced by the Faculty of General Dental Practitioners on prescribing, and also the British National Formulary. So we decided that our standard would be as long as the prescribing complied with either NICE or SIGN or the FGDP or the BNF. So we establish a standard. So we've got a question is, are our antibiotic prescription patterns appropriate? Question. Object, and then we have the gold standard, and we've identified those standards. Then we had a data collection form which collected information about diagnosis, antibiotic prescribing, dose, duration, and whether there was follow-up. And then we were able to look at what antibiotics were prescribed. We were able to look at why those antibiotics were prescribed. And we were able to look at whether people were reviewed. We were able to see whether microbiology samples were taken. And we were able to then test that against the gold standard. And having thought about what the gold standard was, we looked at whether the dental hospitals across the United Kingdom met that standard. And obviously we were interested in our own dental hospital. For example, we looked at the justification for prescriptions, and we looked at whether all of our prescriptions were justified. And we discovered that we weren't recording the information correctly, or indeed there was cases where perhaps the patients shouldn't have had antibiotics, but they were given antibiotics. And so we perhaps were right 60% of the time, but that obviously meant that on some occasions we either hadn't recorded the diagnosis correctly, or perhaps antibiotics had been given out that weren't within the guidelines. We looked at whether we were prescribing the right doses and the right duration. And so when we looked at that, we discovered that in some ways we were producing, there were antibiotics being prescribed, that might not have been justified. When it came to the right doses, thankfully, we were prescribing the correct dose most of the time. So we were good in that we were assessing quite a lot of the microbiology compared with others. We were not prescribing inappropriately for antibiotics. This was not for after extraction. So other parts of the country were prescribing after maybe relatively simple tooth extraction. We were not. And also, we weren't prescribing antibiotics when the patient only had pain. So thankfully, we were doing well there. So it's really important that you identify what is being done well as identifying areas where there is potential for improvement. So we concluded that we perhaps needed to record our diagnosis better, and we needed to make sure that the knowledge of current guidelines was good among all of the prescribing staff. And we needed to make sure that we were using the right duration as well as the right dose. So we've got this information, and that all came back to us from a national data set. And then the question was, well, how do we change that? How can we improve? Because we're not getting it right 100% of the time, or even 90% of the time. So this is where you start to think, well, who can help me with this? Who needs to know these results? And why do they need to know? And exactly what do they need to know? So, for example, a clinical service manager doesn't need to know all of the details about all of the clinical conditions. They just need to know that a standard hasn't been met, and give their support to improving that. Whereas the clinical consultants and the departments responsible obviously need to look carefully at the clinical data. Where will these results be presented? And what's the best time to present these results in order to establish change? What we need to do is we need to make the case for change, engage the correct stakeholders, and then try to come up with an action plan. So we need to think to ourselves, who can make decisions that will facilitate and enable the changes you suggest? There's possibly not much point asking me to change things if I'm only one of 10 consultants in the department. There's possibly certainly no point in asking me to change something if it's a dental nurse issue. The dental nurses and the dental nurse managers need to be involved in that. What information do they need? How can I present my results in a way that the people who can attribute resource or can make change can interpret them, and I take on board my persuasive message and then make changes as a result of it? And so, having thought through all of those areas, we come up with an action plan. And the first thing we did was we circulated the National Summary Report. We circulated the conclusions and recommendations on a Glasgow hospital report, and we sent that to all of the clinical leads throughout the department. These are the most important people from the point of view of clinical change within the hospital. And then we arranged for the results to be discussed more widely at departmental clinical governance meetings. So this is places where the lab staff, the nurses, the junior staff, the middle grade staff, and all the consultants are present, and we can discuss the results at all of the different departments in hospital. One of the things that we decided to do was to nominate an antibiotic stewardship champion, a person who would be the go-to person who would really advocate for antibiotic stewardship in each department. And then we would arrange staff training on national guidelines and recent changes. And so there was online e-learning packages, which we made sure all of the staff went on. And we made sure that whenever a new person joins the department, the hospital, they would be given instruction and induction and training on antibiotic prescribing. And so, having identified a problem, we've engaged with all the stakeholders, came up with an action plan, And then we would carry out a second audit cycle in order to see how things hopefully have improved. And so that gives you an idea of a single example of a quality improvement project. Identify the problem, compare with the standard, see whether you meet it, make the necessary changes, and then re-audit and re-evaluate. But sometimes when we try to re-evaluate, we discover that there are barriers to change. I'm sure you've experienced that in your practice, in your hospital, university, wherever you might work. There are people who don't want to change. The barriers to change can be thought about in this little diagram here. First of all, there needs to be a dissatisfaction with the status quo. If people are happy, then they're not going to change. If people think everything's great and everything in the garden's rosy, then they're not going to do anything different. So we need to create, first of all, a dissatisfaction with the status quo. This is rubbish. We're prescribing too many antibiotics. This is rubbish. People's periodontal treatment has not been successful. People are waiting too long for treatment. Teeth are being lost. Cancer diagnoses are being missed. Dissatisfaction with the status quo. Then we need to present people with a vision of something better, a vision of a possibility that's better than the current situation. So you need to, first of all, create dissatisfaction with the status quo, then a vision of a better future. And then you need to take the first steps. And you will experience resistance to change, but only then can you move forward. So we can sometimes identify those barriers to change in advance. So we can talk to key staff and users. We can have discussions with the clinical teams as we did in the antibiotic audit. You can do questionnaires. Perhaps people will find it easier to be truthful filling in a questionnaire than they will in a one-to-one situation. We can observe work patterns and say, people are prescribing antibiotics because all the toothache patients are coming in with 10 minutes to 5 when everybody should be finishing up. So we'll give more time for the toothaches, and then we won't have to prescribe inappropriate antibiotics. So look at the pathway of care. Look at the work patterns. And team meetings, often your best resource is your team who can tell you what needs to change. And it can be helpful in quality improvement to use one of these tools where we can record what are the positive factors, what encourages people to change, to improve, and then to identify the restraining forces. What is stopping people changing? Why can't we improve? And so we want to write down a list of reasons that are good for change, things that drive change, as well as a list of things which are holding back progress. Write them down, lay them out, and having identified them, at least then you can start to do something about it. So what are some of the common barriers to change? Well, people might say, I've got a lack of knowledge. I've not been taught what to do. They may say, I've got a lack of skill. I don't know how to do this. I don't know how to do this. They might say, it might be a lack of time. I don't have time to do it that way. A lack of belief. I'm not really sure it matters. I'm not sure that's the right way to do things. I think the way I've been doing it for years works fine. So it may be a lack of belief. So in order to establish the need for change, we need to share and discuss our findings. We need to then define and agree the goals. And we need to come up with a tailored strategy that will get us from A to B. And then we can't make all of the changes in the first instance. So it's important to select the right change that will result in the biggest difference for the least disruption. And then having done that audit, I can't change. I'm a restorative dentist. Most of the antibiotics were prescribed in oral surgery. So I can't fix oral surgery. It's not my job. I don't work there. So what I need to do is to make sure that I can engage with the people who have the power. So I needed to pass the information to the lead clinicians in oral surgery, who were more than happy to make the changes. But I can't change another department. So if I don't have the power to act, then I need to make sure that I can influence the individuals who do have that power to act. Some questions that you want to think about in terms of implementation. So how can you design the change? Consult widely and involve other stakeholders. I always tend to think I've got all of the answers until I get into a room of other people who are all brighter than me and see life through a different lens. And then having consulted with that wider group, it's so often you find out alternative solutions to your problem. Agree on the detail of your implementation. How and when will you make those changes, and how will you communicate them? There's nothing worse than an audit or a quality improvement project sitting in limbo because nobody's been informed. And then lastly, you need to think about what's your plan to evaluate the changes. If you've fallen short of a standard and you've instituted a change, how are you going to measure to see whether you have improved things? And whenever we look at change, we need to consider the old technology adoption curve. You will have in your department, hopefully, you'll have the innovators and the early adopters. You may well also have the laggards, the people who don't want to change, the Luddites, the people who don't like technology, and the people who don't like change. The innovators are the people who often make a lot of mistakes. They learn the lessons that we can then learn from their mistakes. It's important to have people who are innovators and early adopters. Probably sensible to be somewhere in the majority. Once the technology has, or once the change has been proven to work, then to be the folk who adopt it. And so it's important that we are using established evidence-based protocols and strategies, and we need to encourage the enthusiasm of the innovators and the early adopters. They're easy to get to change. They'll jump on any bandwagon. It's more difficult to get the laggards to be the last ones to join you in your change. So we need change sponsors. We need important people in the team who are going to change things. And they're going to be our change managers. And we want to use those early adopters to get enthusiastic, to make the changes, and to encourage our next wave of change. And then we need to check whether that change has made a difference. And I guess I would say where quality improvement projects fail is the question of sustaining the change. And that might be a subtle change from what we call quality improvement to quality assurance. So having attained the standard, we need to maintain that standard. So having attained the standard, we need then more of a quality assurance process where we make sure that what we have said we would do and what we have achieved in the first round, that we maintain that and it doesn't drop off. And again, we're just coming back to using this process. Not so much we've done it, it's fixed, let's forget about it, but it's a constant process of keeping checking and keeping tweaking and keeping making slight improvements and maintaining the system. So we don't just do one cycle, but we repeat that cycle, and we want then to easily capture the necessary data to make sure that we're maintaining the standard that we've set for ourselves. So a couple of hints and tips for good quality improvement projects. Good to be multidisciplinary. Most problems are systems problems and are multidisciplinary in nature. You want to choose something that is a major problem if it goes wrong. Choose a high-risk problem, because then when you fix it, you will be saving lives or saving teeth or saving a big problem. Pick something that's high volume. Don't look into, how many people have got dental caries, who've got Creutzfeldt-Jakob disease. Don't choose something from some obscure clinical problem that nobody else is aware of. High volume or a high cost. Where can you save money? Where can you save time? Where can you save lives or teeth? And ideally, fitting in with national priorities. Use service users to find out what they want in the process, and make sure that we include assessment of the process and as well as the outcome. Sometimes the outcome might be okay, but the process by which it's achieved might be clunky, unpleasant for the patients. Standards should be derived from good quality guidelines. So look to the national and international guidelines for your gold standard. And make sure we use that QI process where those action plans are actually implemented as a result of audit findings. So what are the benefits of quality improvement to your practice? Well, it identifies and promotes good practice, and it can lead to improvement in service delivery and outcomes for users. And it can provide us with the information that we need to show others that our service is effective and cost effective, and then thus it can help us in the development. It provides opportunities for training and education, and it helps us to make good use of the resources that we have, avoiding this unwanted and wasteful variation, being more effective and efficient. And it can also improve working relationships and communications between staff and service users and other agencies, because we all realise that we're all part of the same process on the patient's journey. So that's, I think, a whistle-stop tour of the topic of quality improvement in healthcare. I hope that's been interesting, and thank you very much for your attention. And I'd be happy to take any questions from the participants.
Thank you, Dr. Douglas Robertson, for that wonderful lecture. And I think we have understood what are the barriers to adapt to the change and how to overcome them and how to implement them in our regular practice to deliver a good quality, high quality health services. Thank you. Are there any questions? Just a minute, sir. I will find out if there are any questions from the audience.
Okay.
Sir, may I ask you a question?
Yep, of course.
So how do we begin, actually, if we want to improve the quality of health services? At what stage, at what level should we begin, and how do we move on to improve the quality? If we are new to that.
Yeah, I think it's probably something that needs to be embedded across the service. But having said that, we can, all of us individually, improve our own clinical outcomes by using the quality improvement process. So any of us, whether we're in a one-man dental practice or whether we're in a large teaching hospital, all of us can, when we observe something that maybe doesn't seem to be working as well as we would like, well, you look and you think that doesn't seem good quality. So let's look and see, has someone published a guideline? So is there a national guideline that says, everyone should have their periodontal health assessed once a year or whatever that might be? And then say, okay, well, did I meet that? Even just either me and my practice or my department or my hospital, depending on who you are. And so you can, no matter where you are in the process, you can say, is there a standard? Did I meet that standard? And then once I find that out, if I didn't meet the standard, I can think, how do I change? And then it's very easy for us to change ourselves. That is a very easy thing to do usually. If it's just me and my nurse in my clinic, I should be able to make that change. And then I test myself to see whether things got better. It's harder, obviously, across a whole organisation, but the NHS in Scotland has really embedded national audits and the whole teaching and training and quality improvement is something which our undergraduates get, our postgraduates get, even our general dental practitioners are all involved in national audits. And so hopefully it's a technique that we can use from an individual level up to a national level.
Thank you so much, sir. Are there any other questions?
I think there is a question from audience. Sapna, can you address it?
Yes, sir. Just sir. Sir, I will find out the question, sir. Just a second, sir.
Okay.
Shall I read the question?
Yes, sir. Thank you.
A participant has congratulated you for a vivid presentation. Would you? The question is: would you agree that change managers play a vital role to break inertia?
Yes.
Shall I read the question?
Yes, I would agree that that change managers can move things forward. I don't think that person needs to have the job title of change manager. There are people, and that's their job. They manage change for big organizations. And I think within a big organization, you might have a person who is a change manager, and that's a whole discipline in itself. Probably more likely in a health service, you would have senior clinicians who would have been taught or trained in change management, and they can use those strategies to overcome the barriers to change and overcome the inertia and carry things forward. So I recently did a small course in change management because I believe that's an important part of being a senior clinician.
So I have a question myself, Dr. Ramesh. I'm a practitioner.
Yep.
So, general dental practice. So,
yep.
Should quality improvement process be applied in a clinical scenario in our country or in our situation where it is more of a need-based treatment requirement rather than a preventive-based treatment requirement?
Yes, absolutely. I think dentistry, all forms of dentistry, can benefit from quality improvement process. I suppose in terms of need-based, you still want to know, well, how many people got unnecessary antibiotics. That would be a good example. We know that the biggest crisis looming for humanity is the overprescription of antibiotics. So you may want to test yourself against national guidelines on the true reasons for giving antibiotics, and to make sure that you as an individual, or we as individual dentists in India, are complying with the guidelines. So that would be an example of wanting to avoid over-prescription of inappropriate antibiotics. That would be wholly appropriate for any dentist, just to make sure that they are not over-prescribing. I suppose in terms of how many people, how long did people wait who were in pain? Did they get seen the same day? Or did it take a few days before you were able to see them? How long were they in pain for? So I think the process can be used no matter what you're trying to achieve. If you want to achieve an improvement in what you want to do, then the process can be used. It can be applied to almost any clinical problem.
Thank you, sir.
You're welcome.
There is a question from a participant. So the participant has congratulated you for a nice talk.
Thank you.
But what strategies can be used to overcome the initial resistance of quality initiatives? And would also like to ask, what are different ways and means to obtain feedback on quality initiatives?
Okay, I just missed part of that first sentence. Could you repeat that first question?
Yeah, I will give you the first question. What strategies can be used to overcome the initial resistance to quality initiatives?
Okay, I think what you need to do is you need to create a dissatisfaction with the status quo. So people need to believe in better. People need to believe there's a better way to do things. So, for example, if you're happy with people waiting for a week to get their toothache sorted, then everyone's going to be fine. But when you think, so last week, my wife had toothache and she was in agony, and she was told to wait for 2 weeks to have her toothache dealt with. While I was sitting at a desk in a hospital, 2 weeks didn't seem like a very long time. But 2 weeks with a wife with agonizing toothache, I immediately managed to arrange for someone to help her. While I'm satisfied with a waiting list to come and see me to have toothache dealt with, then that will continue. But what you need to do is you need to create a dissatisfaction with that. This isn't good enough. This needs to improve. There is something wrong, and there is a way to do things better. And that is the thing to do, is to, if people are all happy and content, then they'll never want to improve. So sometimes it's important to lift your eyes up to the horizon and see how things could be better, and then catch a vision of an alternative reality. So first of all, create a sense that we're not happy providing substandard treatment. Number two, have a vision of a better process. And then you need to get people on board, willing to join you in making those changes.
The other question was, what are different ways and means to obtain feedback on quality initiatives?
Okay, so sometimes we use questionnaires. So sometimes you might use a survey to do that. And we sometimes use online surveys, quite easy to do. Sometimes we use forms that are filled in at the time when procedures are being done, and you just have a little short structured questionnaire that goes along with it. And sometimes, so you could use online questionnaires, you could use paper forms in the clinical notes. You can also use patient feedback, so you can interview patients and see what they thought of your service. You can also, if you've got a good electronic patient record, or even if you've just got a paper-based record, rather than going prospectively, you can look back at old notes and see how you did in the past. So you can use your old clinical records to see how you've done in the past, and then make changes, and then maybe monitor those changes going forward. Does that answer the question?
Yes, sir. Thank you. Thank you. Dr. Sapna, any other questions from your participant side?
No, sir. There are no questions.
So can I ask one more question?
Yep, of course.
So do you think success and quality improvement process are directly proportionate to each other?
Well, I suppose it depends how you define success, because success could be your implant stays in. So your implant might stay in, but it might be a terrible process. The patient might have been in pain. It might have taken years to happen. It might look terrible. So I think it depends. We need to define success. But yes, the use of the quality improvement process will result in generally in improved success in your clinical for the patient journey and for the patient's experience, as well as the clinical outcomes.
Thank you so much, sir. Thank you. Thank you for your time. Thank you for the presentation. Dr. Sapna, you can carry on with the other formalities.
Thank you, Ramesh, sir, for moderating the session. Thank you, sir, for that enriching lecture. We have come to the end of the session. It is said, feeling gratitude and not, sir, sorry for the interruption. Before I proceed, I would like to invite our moderator to kindly hand over the certificate of appreciation to our speaker. Certificate for the speaker.
Thank you very much.
Sir, kindly accept it. Thank you.
Thank you.
Now, may I request our organizer to kindly hand over the certificate to our moderator.
Thank you, Sapna. Go ahead.
Thank you, sir. It is said, feeling gratitude and not expressing it is like wrapping a present and not giving it. So, I take this opportunity to express my heartfelt gratitude to each one of you who made this program possible and successful. Firstly, I would like to extend my sincere gratitude to Bangalore Academy of Periodontology, especially our beloved Dr. Muhammad Faizuddin sir and Dr. Ramesh sir for having faith in us and giving us this opportunity to host this program. Secondly, I thank Dr. Sridhar N. Rao, our former head and international coordinator for this program. Because of his effort, this program has become a reality. Next, I thank from bottom of my heart our principal, Dr. Asha R. Iyengar, and our ever supporting management for their continuous support and encouragement and providing us all the facilities required to conduct this program. I thank our speakers, Dr. Douglas Robertson and Dr. Keshav Prasad, for agreeing to be a part of this session in spite of their busy schedule and for sharing their knowledge with all of us. Thank you, sir. I thank Dr. Reena and all her team at IGCR online platform for the technical support from the start to end. This event was such a cakewalk only because of your constant guidance. Thank you, everybody.
Please thank RGHS.
Sir? Sorry, sir?
Please thank Rajiv Gandhi University of Health Sciences.
Yes, sir. Definitely, sir. Thank you, sir. Thank you. I sincerely thank our university, Rajiv Gandhi University of Health Sciences, Karnataka. With their association, we have been able to conduct this program. Thank you, university. And next, I thank our HOD, Dr. Sucheta, guidance and support. And I also thank my colleagues, postgraduate students, technical team, and duty staff for the help in organizing this event. I extend my gratitude to all the life members of Bangalore Academy of Periodontology for being a part of this event. Last but not the least, I thank all the participants for taking interest in this program and making it a huge success. Thank you once again. I hope you are now enlightened with knowledge, and I definitely know that you would be implementing these tips in your practice to deliver a quality healthcare service. Thank you, one and all.
Thank you.
Now we may conclude the session.
Thank you, sir.
Thank you, sir. Thank you, everyone.
Thank you.